Did you know? Let's go.
You've waited all week.
Every week, we continue to learn how to achieve a better back and ultimately better health.
Live in the WIKB studios, this is Dr. Larry.
Well, thank you for that, Blessed Pastor Reed. Hello again, everybody. Okay, let's get it started. Well, as you know, every show builds on the next. Every week, we continue to learn how to achieve a better back and ultimately better health. Now, in case any of you missed it, last week we talked about knees. It was an important week to be tuned in because we learned and defined about knee anatomy and some injuries to the joint because, let's face it, we might need a replacement at some point. So here it is again. We've all heard somebody say, I've got a bad knee, or maybe we say it about ourselves because we ache as we age and our knees begin to rattle like a cage. Or maybe you're the weekend warrior or athletic type, and after many years, you know that pain or noise in your knees just ain't right. So eventually, at some point, many of us will have to handle some type of bone, joint, or knee issue. So where do you go for a knee that's about to blow? Yes, it's a field of choices, but when it comes to choosing an organization of experts for something as important as our knees, you want to pick a place that cares for you, like your mom, dad, or Grandma Louise. So our previous guest, and also coming up on this week's guest, is a practicing physician, board certified in a specialized field of bone and joint care, and he specializes in treating bad knees, including partial knee replacements, which was and will be the main focus of our show last week. And part one was last week, and upcoming and part two series of our partial knee show, partial knee replacements. He's also a partner of an organization that has its processes and people, quote, operating like a well-oiled machine. Get the little play on words there? So for the sake of simplicity, I called the segment Ask OSMS. And here's a list of some of the questions I went over with Dr. Flannery. Number one was locations of where he sees patients, which was is Marinette and Green Bay. And since he's been on the show, he's had a nice increase of patients coming to see him for various problems, including anterior hip replacements, as you just heard on telephone time, torn meniscus case, rotator cuff repairs, and evaluations on knee fractures. He's originally from Anago and enjoys meeting folks from Iron County and the surrounding broadcast area. Also, a little fun fact. Dr. Flannery loves to work his smoker at home. Smoked meats, yes. A little bit further in part one of the series last week, we had a general discussion about knees. It was school time. We went over the key anatomy of the knee. Basically, there are three compartments. Key functions of the knee. It's a hinge joint with a little rotation. We further discussed the type of knee injuries, sprains, and ligament tears, which will be an offshoot of another show we'll do maybe later on in the summer about meniscus tears and repairs. And he differentiated between what a sprained ligament is versus a tear, and as far as patient presentation goes. Also, we discussed fractures of the knee, meaning there were several cases recently where patients injured their knee, went to an urgent care hospital, got x-rays, was told no fracture. However, pain persisted, and Dr. Flannery took his own set of x-rays at OSMS, reviewed them, and located a fracture. One of the cases was actually a local lady that I had sent him who I evaluated and was suspicious something was missed and referred her to him, and the fracture was found. So in our discussion about knee fractures, Dr. Flannery brought up a few key points that I want you to remember. Number one, sometimes small fractures show up a bit later because the bone is healing already and it can be detected. Number two, OSMS has their own X-ray and MRI, and they tend to have a higher quality resolution. Also, he reviews all of his X-rays, which is key when it comes to X-raying these special joints. So that was some of the highlights of our 1 hour show on knees last week, and stay tuned for part two in just a moment because we're going to dive into the actual partial knee replacement, and I had some extra questions on top of it at the tail end of the segment as well too. However, if you missed the entire show and want to be more in the know, then log on to my website, drlarryradio.com, hit the subscribe button, follow the links to become an official subscriber. That show, along with 50 others, has been uploaded now, which you can listen to at your leisure as a podcast. It's a must listen. There's also a 7-day free trial. Other than that, it's $7.99 per month. These are all just an archive of my old shows that you can stop, watch, or stop, listen, repeat. Great option as well, too. You can also key tab and search for different show topics on there. That's an option as well, too, if you want to hear a show about, let's say, low back or hip replacements. So here's a final point. If your knee is swollen and an aching, just remember you're probably not a fakin'. Now, beyond that, in addition to the knees, Louise, last week we learned a simple self-test for tendonitis of the elbow. It was another Dr. Larry Cool tool. You can call my office for a freebie reminder, just in case you're in need of a retip or a tip up. And so that was last week. Hi-ya! Now today, we'll forget that monologue for a moment and keep remembering those mandatory communication skills all doctors must have, which are inquisitive listening and staying positive. Again, it often means the difference between sick and well. Also, it's another month of the year, so let's keep our thumbs in gear. So in our tip and trick segment today, we're going to learn a simple self-test for tendonitis of the thumb. And of course, you, Rito Dorito, are calling out right from the broadcast booth while we crank up the tunes and I hit the center stage for the demo. However, before all that, in order to have good health, you don't need a lot of wealth. So let's flex our forebrain and put some knowledge to the game, because today we're going to talk about, hit it, Pearl.
Dr. Larry brings you another segment of Did You Know?
Mini-series are fun, so let's get ready to run into part 2 of our 2-part series on knees with Dr. Flannery. Or rather the run, how about he just walk us through the partial knee replacement, prep, type of incision, tools, hardware, and then a little bit through the procedure, and then discuss some of the, when you actually get in there and see it, maybe some of the anatomical changes that you see from as the knee starts to deteriorate. If you mind doing that for us for just a minute or two.
Yeah, no, absolutely. Sounds good. So yeah, we position the patient on their back, and I use a foot holder so that we can bring the knee up and down into flexion and extension easily. We prep with chlorhexidine, and incision is drawn over the front of the knee, kind of centered over the kneecap and down towards the top of the tibia. And same positioning as for a total knee replacement. So we could use that same incision if we ever had to go back in there. The incision's just smaller, so it just stops pretty much right at the top of the kneecap as compared to going up more proximal. So we use a tourniquet for the surgery, so essentially bloodless while we're working. We make an incision through the skin and the subcutaneous tissues, and then we come down to the capsule. And we really feel where that kneecap is, or the patella, and we can see the muscles of the quadricep, and we look to work along the medial side of the kneecap, and then we're able to expose the joint. So we slide the kneecap over to the side, to the lateral side, and then we can take a good look at the knee itself. And so first thing I typically do is inspect the other compartments that we're not planning on replacing, making sure that they look pristine. If there's concerns there, we have equipment to do a total knee replacement readily available. So then we look at, if it's that medial side, and a lot of times we are impressed, where you can have really kind of deep grooves in the bone where the cartilage was completely wore down. There may be some bone spurs that are sticking off the side of the knee. And so those areas we're looking to then remove those surfaces and replace them. And that's what we do with some guides that we have. So we start with the tibia, and we have a guide that makes sure that we're kind of perpendicular to the axis of the leg. And we look to resect about 4 millimeters off of the tibia side. And we remove any remaining meniscus on that medial side that could be tore up. Basically, we're removing anything that could cause pain on that medial side of the knee. And then we do go to the femur side, and we can kind of think of it like making a Lego piece. We're doing a few cuts around the femur to get so that our component can lock on there well. And our our bone resection, or the removal of the bone with the saw, we plan for about 1 centimeter total between the two sides, and that's what will allow us to put the new parts on and an insert in between of the appropriate thickness to kind of just reestablish the height of that side of the knee. We want to tension the MCL that's next to it, but we're not wanting to over tension it. So we put in trial parts, and we bring the knee through a range of motion, make sure that feels really good. We can adjust the sizes of the insert if we need to. Once we're happy, we prep the bone, remove any blood, any fluid, anything like that, and get it nice dry surface. And then we actually put cement on those surfaces and put the components in and let those harden for about 10 minutes. And once everything's good and hard, we check it one last time and do an anti-inflammatory injection around the knee, and then actually close up the layers and then put a dressing on. That's just it looks like a big Band-Aid, just a simple Mepilex that stays on for 2 weeks. The skin itself, we close with dissolvable suture and glue shut, so nothing to really take out at the follow-up visit.
So a couple things jumped at me. Number one was the fact of the amount of bone removed. Is it roughly on the max side 1 centimeter? Is that kind of typical as far as a max?
It is.
Okay.
It is. Yep.
And as far as to contrast that or compare that to a total knee, what is typically, the amount of bone you're removing on a total knee, if that makes sense of a question? So we're diving into the actual partial knee replacement, and the neat part about this is, and folks, if you've ever gone to a surgeon and they review your stuff and they say, oh yeah, this looks like you need a replacement of your knee or whatever, and then they go over kind of the basics of it, and then you get scheduled, and then you have your surgery, and after the surgery, they kind of tell you how it all went, and then you go into physical therapy. So in a case like where I'm doing a show like this, I'm able to slow down that process for you because there's just not enough time for these docs to explain this process to you. And from them actually doing it, who's actually doing your surgery, by a step-by-step process. So in these interviews like this, I'm doing that on purpose so you can actually hear how it's handled, what kind of decisions they're making, what they're looking at, and then from there you can start to have a better theater of the mind if you do need something like a partial knee replacement, or if you're doing a total or a hip or anything else. So that's part of why I infuse these parts of the interview into the show as well too, because it's just not something I know that's often discussed, because they can't spend 30 to 35 minutes explaining the actual procedure. I mean, they may give you the overview, so it slows down it for you, and hope you're enjoying it. I'm sitting here and listening to it again too. So we've got two more segments coming up. I've got some great data that we went over with partial versus total knee replacements as well. And then we had some Q&A at the end. So sit tight, stay tuned. We're just getting started. You're listening to the Dr. Larry Radio Show. We'll be right back.
Dr. Larry will be back in a moment.
Summer is here and Jensen Akins is ready. We have a huge selection of Flow Docks and lifts in stock and ready to give you the season you've been waiting for. Flow Dock systems are made to bring time at the lake to a whole new level. Strong, stable, safe, and in stock at Jensen Akins of Conover and Three Lakes. The time is now to join the thousands of other families that have turned their dock into a shoreline paradise. It's time for a flow. Stop in or visit our website at www.jensenakins.com.
Since the pandemic, I'm so anxious all the time.
I can't sleep.
I need someone to talk to who's not going to judge me.
For emotional support any time of the day or night, talk to a Stay Well counselor. Dial 1-888-535-6136 and press 8. It's free and confidential, and one of the many ways to stay mentally healthy. Learn more at michigan.gov/staywell. Sponsored by the Michigan Department of Health and Human Services and the Michigan Association of Broadcasters.
This is California Sue, and you're listening to Dr. Larry Radio.
Radio is alive and well here in the UP, and we use it very, very frequently. Hi, my name is Lydia Nowitzki. I represent the Uper Dolls Ladies Disc Golf League. Advertising with WIKB has given us an opportunity to draw more sponsors for our tournaments and other events. It has also widened the knowledge of disc golf in this area. If you have a local event coming up, advertising through WIKB is the best way to get word out.
I'm Kareem Abdul-Jabbar. I learned about atrial fibrillation the hard way. My symptoms would come and go. Shortness of breath, fatigue. I kept going. Then I got so lightheaded, I couldn't. My doctor said I have AFib, so I'm about 5 times more likely to have a stroke. Other symptoms, irregular heartbeat, heart racing, chest pain can come and go, but the risk of stroke stays. If you have symptoms, tell a doctor. Visit notimetowait.com.
Sponsored by Bristol-Myers Squibb and Pfizer.
Adopt US Kids presents What to Expect When You're Expecting a Teenager. Learning the Lingo.
GOAT, G-O-A-T, acronym, stands for Greatest of All Time. As in, spaghetti sandwiches for dinner? They're my fave. Dad, you're the GOAT.
You don't have to speak teen to be a perfect parent. Thousands of teens in foster care will love you just the same. Visit adoptuskids.org. Brought to you by the U.S. Department of Health and Human Services, Adopt U.S. Kids, and the Ad Council.
This local public service announcement is brought to you by Iron River Community Broadcasting.
If your local nonprofit organization has a fundraiser or upcoming local event, Iron River Community Broadcasting would like to help you get the word out. Send your information 1 month in advance to front desk at WIKB.com or bring it directly to us at 809 West Genesee Street in Iron River.
Break's over. Time to get cracking once again with Dr. Larry.
Welcome back. I'm discussing partial knee replacements with Dr. Walker Flannery, orthopedic surgeon from OSMS. We are about ready to transition into a 3-patient success stories with partial knee replacements, and it's a great selection of cases, so hang on. But first, a little insight on the difference in bone removal with partial knee versus total knee. Roll the tape. And as far as to contrast that or compare that to a total knee, what is typically, the amount of bone you're removing on a total knee, if that even makes sense of a question?
Yeah, it does make sense. A little bit more on a total for sure. With a partial knee, if you resected more bone, you could get into the anterior compartment. So
Sure.
we're looking to avoid that and keeping the ACL and PCL intact. So if you resected too much bone, you'd start to get into those ligaments. So yeah, we're really careful on taking a set amount, and I think that's really the difference with compared to a total is the finesse that it takes to do a partial. I think that's part of the reason that not every surgeon is doing it or wanting to do it. Is it involves, I think, a little more art, a little more finesse on thinking about it and balancing it, rather than just kind of going with through the cut jigs and getting the total knee done.
Yeah, I'm glad you brought that up. As I'm sitting back listening to this, it sounds as if, like you said, there's the art science component to it, and a little more finesse as far as that goes, and some detail. My dad's he's a dentist, and then he kind of went into like cosmetic dentistry stuff over the years. He's retired now, but it was more some of the intricate things that he talked about that he liked to get into on the dentistry side of things. So, from what you're talking about from the partial knee, that's kind of highlights that component to it as well too. And then, so therein lies the fact, and I like the other side of things too, where if you need to go back in for a total knee, you're just going to use the same incision. So, no worries about any extra scuff ups. People like to, they like to show and tell their incisions from surgeries. I don't know if all chiropractors get that, but at least the patients that I see, they like to go, look at this, Dr. Larry, and I get to see the knee incisions. I get to see the hip incisions. I get to see these incisions, their back incisions from the surgery. So, I don't know if you know that side.
Right. Yeah.
The show and tell.
It's like the signature. Yeah, for sure.
It is. And it can be years down the road. Look how good that thing healed up, So it's kind of a funny thing about actual incisions. So in this case, you can go right back in at the same incision. Okay. So, as far as successful cases go, how about give us maybe 3 successful cases of, patient, a demographic, what they had, and then what their post-surgical outcomes and how they've experienced it. So get us through about 3 cases as far as partial knee successes.
Yeah. So first case I would have is an individual who was 70. He was really into racket sports. So he played a lot of tennis with the new rave of pickleball. He got into that, and even gave lessons for others, and had this medial sided pain, and X-rays showed that inside was bone on bone, and the rest of the knee looked pretty good. And so I talked to him about, partial and total knee replacement. He had done injections and therapy and bracing and stuff already. And, with racket sports, especially where you have agility movements, kind of jump stop or cutting, ACL and PCL ligaments in the center of the knee are very helpful for function with that. And so we talked about that, and he decided to go forward with the partial knee replacement. And he was one of the earlier ones that I've done here. It's probably been about 5 years now. And he just loves it. He absolutely got back to everything that he wanted to be doing, and has had no pain. And we've had checkup X-rays, and everything has been staying nice and solid on the X-rays. So I think that's a success story for him, and I think he'll finish out his days with that partial knee replacement.
Excellent. Yeah. No, I just did an eval. I'm sorry.
Yeah.
So I had a
go ahead.
mid-70-year-old gentleman, and so I had to send him for a total hip about 18 months ago, and then his knee's been bugging him. He's been climbing up hills, and so I just did some standard radiology on him. I write locally here. I just write it through the hospital, but I just did his consult this morning and go, what? I go, you're going to need a knee replacement, but it's not totally bone on bone yet. So now as we're sitting here talking, and I'm like, it's the medial side that's actually more worn than anything. And he's an active guy. He's always in his yard doing stuff. So here in line, just very timely in the fact that, 70-plus-year-old male, retired but active, and the knee isn't totally shot. And he looked at me, he's like, well, you're just the bearer of great news for me always. Like, hey, it's my job. I got to tell you when things are wrong, But I may reroute that discussion when I see him again, because he was kind of gave the old, okay, all right, well, let me think about it for a little bit. So he may even listen to this segment as we're talking about as well too. So, but okay, how about another case too?
Yeah, so I had another gal that was 46, and she had seen multiple surgeons, and she was just told that she was too heavy for knee replacement. And sometimes we see that as I think a little bit of a cop out in terms of the decision for replacement. So it said she had to lose weight and stuff like that, but also said that was in combination with her being too young, that she was just too young to have it as well. And when I saw her, she was just in tears. I mean, just terrible pain, and she moved her knee. It was just grinding, and she would do stairs backwards, and couldn't sleep at night, and had done all the conservative treatments. And so for her, we kind of helped her get set up with a weight loss plan, and we had her come in and do regular weight checks, and kind of helping her with modifying her diet and finding low impact exercise, with doing some pool therapy. And so she got down to, a safe level to look at replacement. And, we talked about, with your age, there's a good chance that you're going to need another surgery in your lifetime, whether it's partial or total knee replacement. And for her, it was completely the anterior compartment that was just grinding bone on bone. She had some knee dislocations, or kneecap or patellar dislocations when she was younger that caused damage to that joint. And the rest of the joint looked good. And so we did a patellofemoral or anterior compartment replacement, and she did wonderful. Even at the first visit, range of motion was around that 0 to 110 range. She's like, I'm looking forward to doing stairs, and ultimately she was having no trouble alternating on stairs, and healed up really well with full motion that was symmetric with her opposite knee. So she was just tears of joy. Then eventually at her final follow up. So she did great with that as well.
I'm glad you. So I folks, just I have no idea what cases he picks to choose to talk about. And from the last interview we did with the anterior hip, I thought you did a great job of selecting out of the pool of people some great spread of demographics and styles of cases. So I don't know which ones you're going to talk about and how you're going to describe them. The second case is interesting because, like I mentioned when we were talking before we started doing the interview, I have mini segments that are rotating constantly. And they're basically mini Did You Knows with Dr. Larry, and they're educational 1 to 2 to 3 minute rotators I have on the radio station. One of them is actually about that type of case. I've run into cases before where a patient comes in, they may be coming in for, just an evaluation. Sometimes, just locally in the area here, people know I do bone, joint, hip, knee, any movable joint evaluation and give recommendation advice or referrals. And so I have cases come in where I'll have people that had seen another provider, orthopedic, told that they were too heavy and they would not do any knee replacement and not work with them at all. And in one case in particular, which was the genesis of the mini segment I did, was lady needed. Actually, she walked in, she was wobbling side to side, miserable pain. She came in with back pain. And I said, I know your back is bad, but what's going on with your knees? And then she told me the whole story. She goes, well, I need to have 2 knee replacements, but they won't do it. So I rerouted her and got her, and she ended up getting 2 knee replacements, and she's doing wonderful. She can walk up and down the steps again, feels more motivated, active to lose weight. So the fact that you brought that up as a case, and then in addition, you got involved in helping that patient even stair step down some weight with some therapy activity and some other modifications, and then she could have, now in this case, not even a total knee, but a partial knee, was an excellent case to bring up. And I just kind of wanted to square that in a little bit more. As folks, if you're listening to what Dr. Flannery is saying, if you've had an opinion and you are carrying some extra weight and you were told that you are got to lose weight first, then we'll do the knees, that is not an entirely it's an opinion, but you should get a second opinion, I guess is my point. And in those cases, folks like and doctors like Dr. Flannery would be more than willing to talk to you about that and work with you so they can get you back to more of a functioning, healthy, pain-free lifestyle, like in this second case that they went over. So good choice on that second case. Let's go over a third one. So we're getting hinged to this interview with our knees. Now, as you've heard Dr. Flannery come on the show now twice, first with the anterior discussion and now knees, I'm getting a sense of the type of character and practitioner he is. And now after that second case he just went over about helping the lady who had grinding knees and needed a knee replacement, and then they helped her with diet modifications, stair step down a little bit, and then get her the knees that she did. And then even made comment to the fact that just not to walk away from the patient, be like, well, when you lose weight, call me. They actually took an approach to try to help the patient, which is essentially like an oath that doctors we're all supposed to have, is to try to help you out as best we can within our sphere of influence. So no doubt this translates to excellent bedside manner, very practical and genuine explanation he is and does. Also, listen to a few of his 5-star reviews online. Here's what patients have had to say about his expertise as well. Here's one quote. My experience with Dr. Flannery has been positive in every way. He is a compassionate kind. He listens and answers all of my questions. I had surgery on September 6th, and Dr. Flannery did an amazing job. I went home the same day and have had any issues with healing. Everyone involved with my care at OSMS has been amazing. I'm happy to say I'm on the road to more active lifestyle. That was a review of Dr. Flannery. Here's another one. Dr. Flannery is awesome to my son. He did a great job explaining how the bones heal, and with his guidance and knowledge helped to avoid a collarbone surgery. Walker Flannery is a skilled surgeon. I experienced only mild pain as a result of a shoulder replacement surgery. During our follow-up meeting, he was very professional, kind, giving, and gave me all the information I needed. And here's another couple ones as well, too, before we get to the final third case. I have nothing but good things to say about Dr. Flannery. I've been going to see him since 2015, and ever since he's been great and has taken good care of me. I had a partial knee, so this is timely for what we just had, in 2020 of December. He was great with that as well. He listens to you. He takes the time to explain all of your options before taking any steps towards your care, and ultimately leaves the final decision up to his patients, which is awesome. In the final review, I just kind of hand-selected some of these. I met with Dr. Flannery to discuss the anterior approach to hip replacement surgery. He was thorough in his explanation of the procedure and what I could expect afterward for recovery and getting back to doing things I want to do. He answered any questions I had and was very personable. I will be having my surgery in December and looking forward to leaving the pain behind. So that was a small sample of his 92 positive reviews. And so when I'm selecting doctors to come on the show, these are the type of folks I like to work with. These are the type of folks I like to refer you to, and these are the type of folks that I like to bring on the show. Not all behave this way. In the midst of it, a lot of times, I'm sure all of us at some point have been discredited and we've not been heard or taken care of from a healthcare practitioner. And so when you have practitioners that act and behave a certain way, not only do they have to have good bedside, they have to be experts at what they do and have good experience as well too. So it's kind of a full package, which is why I brought him back on the show, and he did a great job. So we're going to listen to the third case, one more excellent case, a cancer case and a partial knee replacement. When we get back from the break, stay tuned. This is the Dr. Larry Radio Show. We'll be right back.
We'll be right back with Dr. Larry.
Paid for by Christian Care Ministry.
Let's see, if something costs less, but people are happier with it, that sounds like something to look into, and that's MediShare. Maybe you've heard switching to MediShare to pay for healthcare can save the typical family $500 a month. And that's huge, but it's also true that people are way more satisfied after making the switch too. The customer satisfaction rate for MediShare is double that of the typical health insurance plan. MediShare works. It's been around for more than a quarter century, and members have shared more than $3 billion of each other's bills. People love having telehealth and a huge nationwide PPO network. So yeah, you can save a ton and like it better. Imagine being happy with how you're taking care of your health care. So if you're self-employed or part of the gig economy, or you just want a plan you're happy with, you can call right now and get a price within 2 minutes. A very, very smart use of 2 minutes. Here's the number you need. 855-51-BIBLE. That's 855-51-BIBLE. 855-51-BIBLE.
Your WIJB weather is brought to you by RE/MAX North Country.
RE/MAX North Country, working hard behind the scenes to make buying or selling your home as smooth as possible. That's why more buyers and sellers would recommend us to a friend. Crystal Falls, Iron River, and now Florence.
Here's your Iron River and surrounding area forecast. High of 74 this afternoon under sunny skies, northerly winds 8 to 15 miles per hour. Clear skies and quiet again. Tonight, lows sit down to about 36. 79 tomorrow, mainly clear. Chance for scattered thunderstorms. Saturday, chance for scattered rain showers on Sunday. From the Weatherology Weather Center, I'm meteorologist Jennifer Wojcicki on WIKB. Currently, it's 74.
This is Cindy from Long Lake, and you're listening to Dr. Larry Radio.
Could there be a better name? Auto Value Parts Stores. They aren't just about air fresheners or fuzzy dice. Auto Value Parts Stores are all about parts, auto parts, and advice. Pros who know auto parts with tons of tips when you need them the most. You want real value? Don't go to a place with a cute name. Go to Auto Value. Could there be a better name? I didn't think so. Your Auto Value Parts Store. We've got the parts, we've got the smarts.
From gooey grilled cheese sandwiches on Dakota-style 12-grain to peanut butter and jelly on Kids' Choice soft white bread. Kids of all ages want simple, comforting food that remind them of mom's home cooking. Country Hearth was born from that nostalgia and commitment to simplicity. Baked locally using natural ingredients like whole grains and honey, our breads are delivered fresh daily to grocery stores throughout the Midwest. Country Hearth Breads, baking our best for you.
We're back with Dr. Larry.
Welcome back. Well, we are going to get into the third and final case about partial knee replacements. Dr. Flannery is going to walk us through a lady who had cancer and also needed a partial knee replacement as well, too. And he's going to talk about that here in the last segment of the show. This concludes, and this will be the last final part of this knee replacement. Again, don't forget to, while you're listening, if you want to hear this show again or the anterior hip show, all those can be found on my website, buying through drlarryradio.com. There's a subscription button there. All you have to do is click that as well. Okay, so let's hear this case on the third final case about a partial knee replacement. Roll tape. Good choice on that second case. Let's go over a third one.
Yeah, so a third case that I would have is a gal that had dealt with cancer and was medically not fit for surgery, and was able to control that, get into remission, and came in and was evaluated, and she's like, "Doc, I have severe pain to both of my hips and both of my knees," and sure enough, we get x-rays, and both hips are bone on bone, and the knees have severe arthritis as well. And for her, it's like, just kind of taking that all in and coming up with a game plan to attack it, I think was quite the challenge. So, we started out with picking kind of the hip that was the worst, and we were able to replace that, and did injection for her knees and some therapy and some other non-operative treatments, and made sure she had a good outcome there, and kind of worked our way through the joints. And over the course of a year and a half, she had both new hips that she loved, and with the knees, ultimately ended up having a partial knee on one side and a total knee on the other. So she's kind of a totally bionic lady, but she, I think, having that option for the partial of just not having the frustration or sort of knowing the type of recovery that she has already gone through with these other surgeries and what she would need to go to, just having that partial be an easier recovery was nice for her. I mean, the anterior hips, she did very well also, but a lot of surgery to have, and especially with having the right knee with the total knee replacement, I think it was just one of those things where I was like, thank goodness, we got a break here, that this one just needs a partial.
Yeah, exactly, and very kind of complex case and multiple components to put together there, and like you said, in a sense, saving her one aggressive sort of surgery, and something like that, people will just take that as a big relief, and helps improve overall mood and attitude as well too. So great mix of cases. I know there's tons more, but overall, folks, I think you kind of got the understanding and the feel for the type of knee, or what a partial knee replacement can do with a qualified surgeon who is willing to apply the finesse in order to see and screen you to see if you're a candidate for that. Okay, so now let's just get objective. What is the data on the success rate of a partial knee replacement long term?
Yeah, so partial knee replacements have a 85% survivorship at 20 years. So all possible issues, 85% of people still have them in after 20 years. That's slightly lower than a total knee replacement, which is 90% at 20 years, which is important to understand, though, that the difference there, the biggest difference, is that the remainder of the knee was unresurfaced. So over the course of 20 years, can other parts of your knee wear out? Of course, it's just your original knee. And so there is that possibility, but a pretty small difference, So if you're in that category of being over age 70 and 20 years is a good outcome, obviously that's great. And then if you're in that youngest category where you're expecting potential for surgery again, either way, I think that's the other category. So it's really bimodal, kind of those two sections that have, I think, the biggest to gain from the partial knee replacement in terms of the longevity. So if you did have the most common reason for the partial knee replacement to sort of fail or wear out or need further surgery is just that the other parts of the knee have worn out, which can happen, especially after a decade of time. And so then you would look to convert to a total knee replacement at that point.
Okay, so as I was just about ready to have people open up, or to open you up to where they're going to get hold of you, I got a question about that, or a comment. So let's just say, okay, so I'm patient A, and I've got the equivalent of the fact that I'm in front of a practitioner that just does total knee replacements, and I get my total knee done, and it's early in life, and no partial knee was ever discussed. And then I run the stats out, and I'm in the, like you said, 85 versus 90% success rate, or until they wear out. Now I'm 21 years in, and my total knee needs to be redone. Now same patient goes into you, gets the partial knee done, and they're in that data pool where all of a sudden after 21 years, the partial knee wears out. Of the two patients, which would you rather have to do? The A patient that's had the total knee and redo the total knee, or would you rather have to do the partial knee and then do the to add on the total knee as far as it goes? You understand what I'm asking here? Meaning,
absolutely, yeah, and it's night and day different. I mean, totally. If you had a total knee replacement, it depends on how the replacement wears out, but most commonly they wear out from loosening over time, and with a total knee, there's just much more bone that was taken initially. And in terms of even the inside portion of the bone. So with a total knee, it's going to be a bit more work to get it out. Certainly a higher risk of infection or complication even from the surgery itself. And we would be looking to put stems down inside the bone to make it nice and stable again. So much bigger surgery. Not that it's not doable. I mean, we certainly do them, and patients can do very well with it. But I think ultimately our goal in general when looking at these surgeries is really trying to have one total knee replacement for someone's lifetime. So if that involves a partial before that, I think that is really beneficial. Sometimes the cutting guide for the total knee replacement cuts right under where the partial knee replacement was fixed before, and it really doesn't change anything that we need to do. Whereas if you have bone loss with a total knee replacement, there can be needs for what we call augments, where you're trying to build the bone back up in certain ports with metal, and again, kind of stems or sleeves that go down into the bone to provide new areas where the components can heal to.
Okay, and the reason why, and thank you for answering that. I put myself into, I will erase what I know, and I will put myself into like an average person who doesn't, live, breathe, and talk bone joint care, pain, knee. They're just going to work every single day. They got a knee problem. And so what I did was I heard the difference between 85, 90%, and on a, no pun intended, I guess, a knee-jerk reaction. Some might think, well, the total knee is better because it's got a 90% success rate and the partial knee is 85%. And the reason why I brought that question up is because the 5% is really kind of a null and void 5%, because if you have a 5% higher success rate on the one and 85% on the other, but the reality is if you do the partial and have to go back in and do a total, it's a much better transition than having to do a total and a total, I guess was my point of my question. And so
yeah, absolutely.
So we don't want to make folks just, and the reason why I asked Dr. Flannery that question is still in a sense, if you got the gist of the show today and what he's talking about, the partial knee replacement is a great thing to get pre-screened, and the 85% versus 90% is essentially a wash when it comes down to the life cycle of it and how it wears over time, if you're a good candidate for a partial knee in any compartment of it. So, Dr. Flannery, once again, second go around, we did anterior hips, we did partial knees, and now we got to do meniscus at some point down the road. Scopes and cleanups on debris, bone spur removal. We got another offshoot segment, but for now, if listeners want to contact you for an appointment, what is your phone number? And also, if you don't mind giving out the website of OSMS.
Yeah, so OSMS phone number 920-430-8113, and otherwise it's osmsgb.com.
All right. Well, thank you so much. You did a great job of explaining everything, and and of the patients from Iron County in the surrounding area that's come to see you, it's always been a very positive feedback, and thank you once again for taking care of the folks.
Oh, thank you so much. It's been a pleasure, and yeah, it's always a big decision on deciding that, and I think it's important for us to just be able to help counsel and give everyone the education so they can make an informed decision, and hopefully we can keep providing good care up there.
Awesome. All right, thanks again.
All right, thank you.